also and certainly also this is seen in the Pacific Rim and in Asia. So again, this is a very common condition. As noted, the primary hallmark of non-surgical therapy has been physical therapy, but physical therapy, unfortunately, is not always available for patients, and also, unfortunately, in many patients, doesn't reach the goal of ultimate therapeutic target, which is substantial benefit. So again, we have a real, if you will, therapeutic gap. And I just like to say in the intermediate set of hexagons, I believe it's colored in the red color. I'm colorblind, but I'm not. I believe where it says QOL, that refers to quality of life. This condition has substantial impact on women's quality of life and can lead to severe conditions such as depression and societal withdrawal. So this is something that really the medical profession has relied on a very few therapeutic options, and we really need new therapeutic options for patients because patients want them, and they want something that they can integrate with their lifestyle without potentially the risks associated with surgical intervention. Next slide, please, Klaus. So this simply on the left-hand side of the slides indicates, if you will, the panorama or the goals or treatment availability. And on the upper left arrow are what we consider a variety of conservative treatments. And again, I've mentioned physical therapy. There are some behavioral aspects that can be done to modify this condition, but unfortunately, those behavioral aspects really involve cessation of physical activity. And of course, that's not ideal and can be very problematic for individual. There are some also vaginal inserts that have been utilized, but obviously that is not exactly the best option for a lot of women with this condition. And then clearly on the other aspect, the lower right, or rather lower arrow on the left, where it says more invasive, obviously there is surgery, and surgery can actually be formal surgical intervention, or there are a variety of injectable agents that can be used to inject into the urinary channel. But again, these are all foreign items. They're not part of the human, if you will, construct, and they are associated with some healing-related phenomena and also the need for convalescence, and are not uniformly successful. On the right aspect, there's a term KOL, which simply means specialists who have really focused on this condition. And this includes not only physiotherapeutic and nursing specialists, but also medical specialists. And we know that unfortunately, a very small percentage of patients who have this condition actually seek treatment. And therefore, they manage the condition for long periods of times without seeking medical care. And again, that delay in treatment often is associated with worsening of the condition with time. We know that the stigma or the societal frustration associated with this condition is significant, and we really have a goal and need to expand education as to this condition as part of the life progression of women and what options exist so that we can help women manage and deal with this condition and overcome it when we're able to successfully identify the individual and help them understand the condition. Unfortunately, many of my peers view the gold standard for treatment for this condition to be surgery. But surgery is not, one, universally successful, nor, number two, universally durable in terms of long-term success. So we really, really do need some way of managing the person's physiology such that we can optimize their personal physiology. And the real hope is that with some of the new treatments that are coming to the fore, which you'll hear about in a moment from Klaus, that we can actually inspire the person's own tissues to evolve in a way that can recapitulate or reform the prior restorative functions that allow them to have adequate urinary function. Klaus, over to you.
Well, Roger, thank you very much. In the next few slides, I want to talk a little bit about the platform and where we are, and then also go a little bit more into some of the data we've generated in this space. I think in Versameb is a startup, a biotech here in Basel, Switzerland, developing our lead indication for stress urinary incontinence. Versameb is an RNA therapeutics company, so we're developing RNA therapeutics, and in particular in stress urinary incontinence, we hope to regenerate the urinary sphincter really to restore its function. RNA has been in the news very significantly, and maybe just recognizing the audience, the diversity of audience. I just want to maybe just reiterate some of the things you may have seen quite extensively in the news over the past few years. I mean, obviously, a lot of the COVID vaccines were actually based on RNA. At Versameb, I mean, we very much think of ourselves as a next generation RNA therapeutics company. And really with the thought that a lot of the vaccines which were developed, of course, they were transforming in terms of being able to combat the COVID vaccines. I think there's really a next step where we can actually take RNA to the next level of being able to use it as a therapeutic. The basis, of course, is that within each cell in our body, we have DNA, which is basically our genetic material. In order for the cell to produce a protein or a molecule which is functional to actually do something, to change the environment, to change the cell next to him or her, it transcribes RNA, and then from the RNA, the proteins are actually produced. Now, of course, the actual thought, and this has been, of course, evidenced by the fact that some of the RNA companies have been around for 10, 15 years, is the idea is that, of course, you can also inject RNA directly into, or insert RNA directly into the cell, and this is what is meant by the little syringe here. And of course, by inserting RNA directly into the cell, we can also work using the cell's own machinery, produce proteins effectively. Similar in a way that some of the drugs we give now are actually protein-based drugs, or even antibody-based drugs, which will have a certain function. So that's a little bit the basics on RNA therapy. Of course, we have, I mean, as a startup company, we believe we have something special, something differentiated, and that has to do with the fact that RNA, or administering RNA, is actually not so easy. And there's quite a few barriers or quite a few challenges to administering mRNA. And that's why I think some of the success you've seen with the COVID vaccines, you've only seen very recently with some of the advancements companies like Moderna and BioNTech have made in this space. mRNA is of course, the body's immune system typically very rapidly recognizes as a foreign body and will actually clean it up very, very rapidly. So a lot of the focus the early companies in RNA have focused on is really to increase the bioavailability of RNA by administering in the form of sort of particular vesicles and having particular formulations, modifying the half-life, really around the idea to increase the bioavailability. I think what sets us apart at Versameb is really that we've actually focused on something else rather than just focusing on the pharmacokinetics, basically what the body does to the RNA. We focused on the pharmacodynamics, actually changing the way the RNA actually interacts with the body. And one of the major modifications we've been able to enhance the potency of mRNA, meaning that we can actually, the mRNA is much more effective than what it is in its naturally occurring state. And we've optimized this by actually changing some of the sequence codes. We've also have further technology, which I won't speak about today very much. We've also developed a linker technology, which actually allows us to modify different proteins at the same time using one molecule. This is a little bit more detailed, but what happens actually when the mRNA and you see the particular strand of RNA is depicted by this wobbly line. When the mRNA gets into a cell, of course, it gets transcribed to the cell's machinery to describe proteins, and then from there it's actually secreted into the cell's environment if it's a secreted protein, so that it can actually have its function outside of it. A lot of the expertise we have actually sit on the front end, this little green part with the cap, as well as on the back end, the long A series. And long A series actually causes intracellular stability, so that you have a certain half-life that actually becomes druggable. And then the front part actually contains all the information for the cell, what to do with the information for the actual protein. And then depicted, I think, for those of you who have worked a little bit more in sort of biology, just showing sort of concentration response curves depicting that we can actually increase the potency significantly. On the indication, what Roger's mentioned, of course, a lot of the injury starts at natural childbirth or with aging. One of the key aspects to this is what we believe is low IGF levels. And IGF actually stands for insulin growth factor 1. It does have something to do with insulin, but also has to do with a lot of other processes in the body. And it's actually a growth factor which, looking at the right graph, actually reaches a peak around puberty. And that's only natural because around puberty, we're actually done growing. And from there on, the actual IGF levels in the body actually decline steadily, declining up to about 80% of where it was at puberty. And one of the things we see is that, of course, there's some variability around this. So certain women may be above the curve and other women will be below the curve. And actually, it turns out that women who are below, on the lower end of the curve, they're actually much more likely to suffer from stress urinary incontinence. This has been published a number of years ago by Alsbeck et al. Women which are above the curve, and this is also what we see, what we see clinically, are actually more likely to actually will have stress urinary incontinence after natural childbirth, will actually recover by themselves. And then, of course, as Roger also mentioned, as people age further, actually the curve declines further, and that also becomes much harder for the muscle, for the urethral muscle tissue to actually recover by itself. So there's very much a basis or a molecular basis for this lack of recovery, which you see as well. A little bit on the therapeutic concept. What we're trying to do is using mRNA, basically injecting the sequence code or the information the cell needs to produce insulin growth factor 1. We actually, which in young people, you would have higher levels of IGF-1, so you see a lot that actually leads to, in the case of damage to tissue repair, you might see damage when you have a sports injury, tissue repair by itself in a matter of weeks. Of course, as you get older, there's less IGF. So you actually see less tissue repair, actually do muscle damage. That's also why, when we're doing sports at later age, it takes much longer if we sprain a muscle than when we were 18. So the therapeutic concept is really around injecting mRNA or injecting the actual sequence code to produce the protein, IGF-1, insulin growth factor 1, to actually get to the same levels as where you were when you were young, so that you can actually stimulate tissue repair very effectively. That's something which we've actually tested in an animal model for stress urinary incontinence. There's actually an animal model. One of our other advisors is a lady called Margot de Meester. And Margot actually developed an animal model in rats to actually show, to actually study stress urinary incontinence and get a much better understanding of the disease model. We've also, the FDA has also acknowledged that this is very much the only animal model for stress urinary incontinence, as is also an animal we use. The model actually involves simulating a pregnancy using a balloon catheter, and this actually results in a condition very similar to sort of stress urinary incontinence in rats. Rats are, of course, very different from animals, so all rats actually recover by themselves after the procedure. The interesting thing is, Roger mentioned duloxetine. Duloxetine actually works in this model, so it actually is also shown that it works both in humans as well as in rats as a therapeutic concept. Using this model, the group of Margot de Meester has actually done a number of experiments also with IGF-1, injecting it directly into the tissue, and you can see the beneficial results on the left. Of course, one of the challenging factors of IGF-1 is that it has a very short half-life. It's a half-life of about half an hour, which means that after a single injection, after about 2 hours, pretty much all the IGF is gone, and actually that results in too little IGF to actually have a full recovery effect. So one of the things that subsequently has been done is a slow release formulation has been built with beads. Of course, beads actually don't make a therapeutic modality itself. This is where we believe that there's a strong rationale for actually using mRNA. mRNA has a much longer half-life, about 15 to 20 hours. And with 15 to 20 hours, it basically takes about 100 hours for the mRNA to disappear, which results in IGF levels of about 3 to 5 days. And that's actually sufficient to regenerate the urinary sphincter. So this concept we've actually tested in this animal model developed by Margot de Meester. And this is a bit of a complex graph, but if we just have a look at the middle graph, we actually see that the actual strength or the pressure which is required for a rat to leak urine actually goes up with VMB 100, the blue dots, quite significantly, reaching a maximum of 9 days. Compared to duloxetine, duloxetine also goes up. It goes down a little bit earlier, but we see a very significant effect. We've also, I think much more interesting, of course, this is a leak point pressure, actually the pressure applied to the rat's stomach, which is a bit of a complex measure. But we've also actually looked at the axial morphology, and I think this is one of my favorite graphs. The actual experiment, I have to say, is actually a very large experiment, but this is just representative cross sections of the urinary sphincter. So it basically means when you look at the urinary sphincter, you take a slice through the middle. This is what you're looking at. And what you see is that if there's no injury in a healthy situation, this is basically what the graph, the top graph on the left, on the top picture on the left. So it looks at it, you see a strong layer of outer muscle, skeletal muscle. And this is basically your urinary sphincter muscle, which after you simulate the pregnancy in rats is very much gone. And this is very much a similar stage or a similar situation which you will encounter in women after natural childbirth, is that you also see that the tissue is much more dispersed. And when you look at the magnification, what you see is that these muscle fibers, which were before thick and strong, actually now become thin and dispersed. And also on the inside, you also have these pockets of muscle depicted by the eye, which is really sort of smooth muscle. And then after natural childbirth, these pockets are gone. And this is something you also see in aging women. This is what that tissue will typically look like. In animals, a single injection of VNV100 will actually result in a regeneration of the muscle to a state where it was before the injury. And so when you look at the magnification, you see the muscle cells, the thick muscle cells coming back. And actually what IGF does is actually it stimulates the stem cells and the myocytes to fuse with the muscle fibers so that you actually get functional muscle tissue back in the space. And we also see this formation of these smooth muscle cells. So this has been quantified a little bit, but I think this is probably the most convincing that we really see this regenerative effect that we can not only reinstall the function of the urinary sphincter, but also really regenerate the actual tissue. And this is what we're very excited about. So this is also what we've taken to the FDA and had initial feedback on the FDA on, really with the question, can we move this into the clinic in patients directly? And this is where I'm at. So we have that with that feedback, we now actually have a very clear path forward. We've completed our first toxicology study in rats. We'll actually be studying the actual route of administration in a larger animal species as well, just to make sure the drug is completely safe. So we're ready to actually, once we have sufficient material, we're actually ready to move into a first-in-human study, what we call a phase 2A study, which will assess both the safety and efficacy in women with tertiary encounters after initial childbirth, following a full IND or an investigational new drug submission with the FDA. Of course, recognizing that this is a very narrow patient population, we'll also look at a broader patient population, including postmenopausal women, in a subsequent study, in what we call a phase 2B study. That's really what we're looking to do. So, appreciating, of course, that there have been a number of webinars also on a little bit later stage treatments. We're a little bit early, but less than a year away from the clinic. We're very excited that we can actually we'll get to test this drug in patients using a new treatment modality, which has been used very successfully, of course, in a very different setting earlier in the year. But actually, being able to help millions of women and potentially also men worldwide a number of years from now. So with that, I would like to thank you very much for your attention, and maybe also just give you the opportunity to ask any questions on what we're trying to do.
Are there any questions? If you think of some other questions later, you always can send me an email and I will forward them to Klaas and Roger.
Absolutely.
Klaas, there is a question in the chat.
Sorry, yes, I see it.
You see it? Okay, good.
Yep, absolutely. No, thank you very much. So Jenny asked if the mRNA is injected directly into the urinary sphincter muscle in rats. And we did a quantitative protein analysis on the treated animals. And this is something I haven't gone into in great detail, but we're actually looking to inject the mRNA directly into the tissue. We know that mRNA works very well in muscle tissue. I mean, also from the vaccines, muscle tissue is very well suited. It's very active tissue. It has a very high uptake, so it readily takes up mRNA. mRNA doesn't allow itself to be injected systemically. I think also for this particular application, it also doesn't make sense. The actual urinary sphincter is a very, very small organ. So to inject it directly is probably the only way. So we injected directly in the rat studies. Of course, the rat urinary sphincter is very, very small, so it's about 2 millimeters. So I wouldn't say we injected into the urinary sphincter, but we injected it in the vicinity. But in a larger species, we certainly injected into the urinary sphincter directly. In the tissue analysis, in the rat studies, in the toxicology studies, we've also looked at quantitative protein analysis, and we do see the protein come to expression in a dose sort of a dose-dependent way very effectively. So yes, we have actually looked at the actual protein levels as well, and we can bring those to expression. Thank you. Thanks, Jenny. Thanks for asking that. Yes, thanks, Milena. That's Milena's asking how much time it takes for the tissue to be regenerated after injection. In animals, we see a very rapid regenerative effect. So the mRNA, the amount of mRNA we're actually injecting, is sufficient to last for about 2 to 3 days, and that results in the protein levels or increased protein levels of sort of 3 to 5 days. Within that, of course, IGF-1 itself has sort of downstream. There's a number of biomarkers. There's about 7 sort of downstream biomarkers, which sort of subsequently go up after each other's, which all sort of work towards regenerating tissue. So within a time frame of about 7 days, you see this tissue regeneration in animals, in rats. Now, humans, I mean, as mentioned, humans are larger species than rats, of course. So we anticipate that in humans, it may take a little bit longer, but it shouldn't take much longer. So we expect that it should be, being in 10, 14 days, you should be able to regenerate a urinary sphincter. Thank you, Milena, for asking.
Any more? Okay, then all. I would like to thank you for attending this meeting. Thank you, Klaas and Roger, for giving this presentation. And well, tomorrow we will have our last webinar. Thank you.
Thank you.
And bye-bye.
Thanks, everyone. Bye-bye.